Good morning. First of all, let me thank the organizers of the conference, especially Rob, for inviting me here to talk with all of you. I very much enjoyed the talks up until now, and today is full of my geospatial brethren and sistren talking, so this day is yet more exciting for me. I want to start actually not with my talk, but with a call to action. I don't know how many of you have followed the EPA's proposed rule called Strengthening Transparency in Regulatory Science. So in April of 2018, oh, I can see it here, that's very helpful. In April of 2018, they issued this initial proposed rule. In May of 2018, the editors of Science, Nature, PLOS, PNAS, and Cell all issued a joint letter talking about all the problems with this proposed rule. There was a public comment period. They received almost 600,000 comments, almost all of which were negative. In November of 2019, there was a leaked version of the proposed revised rule that was published in the New York Times. That was very controversial as well. In December of 2019, those same editors, plus the editor from Lancet, again talked about the problems with it. In full disclosure, I really appreciated Linda saying yesterday the importance of fully disclosing all of your different biases and funding sources and all of that. I wrote an editorial in Science Magazine in December 2019 about this proposed rule. They just issued the revision to the proposed rule on Tuesday night. I will say cynically that it's not accidental that they delay, that the issuance of the revision to the proposed rule came out at a time when many, many people are fundamentally focused on the coronavirus, who might otherwise be focused on this change in the proposed rule. And there is now a 30-day comment period. So if you care about how the environment shapes health and well-being in this country, and if you care about how all of your work might shape regulatory processes and rules, you must pay attention to this proposed rule, and you must get involved with the public commentary and the discussion about the proposed rule. I'd be happy if anyone wants to send me an email to give you more information about how to get proposed, but my sort of little mnemonic for you to think about is every time you hear someone say coronavirus, which I admit is very, very, very important, but every time you hear someone say coronavirus, I want you to ask yourself, what have I done to be responsive to the Strengthening Transparency and Regulatory Science rule? And every time you hear coronavirus, I want you to reach out to 5 people you know and suggest to them that they get involved in the response to this rule as well. This is critical regulatory policy for anybody who cares about environmental health. So, a little bit of a distraction, but I think an important one. I want to start my talk by making 4 key observations. The first one of which is that health is spatially patterned. If you look at this map right here, that's a map from some collaborators at the CDC that shows the percentage of people age 65 or older who have 6 or more chronic diseases. So if you look at that map, and it's age adjusted and population density adjusted, so if you look at that map, there are clearly some spatial patterns going on there. There are parts of the country where we worry more about multiple presentation of chronic disease. So that's my first observation. My second observation is that contributors to health are spatially patterned. So this second map here is also from some collaborators at the CDC. That is a map of the percentage of the population that does not have a high school education. So we know that education is highly correlated with health, and so if we map who doesn't have that, who is lacking in sort of higher educational attainment, once again, the darker the color, the higher the percentage. So you once again see a spatial pattern. So this contributor to health is spatially patterned. My third point is that healthcare resources are, can you hand me my water? Healthcare resources are spatially patterned. So this map right here was done by our research group. It was done in collaboration with the, see, this is why it's so good to have your daughter come to your talk. Thank you. So this is a map that we did in collaboration with the Kellogg Eye Center at the University of Michigan, and it's a map of access to ophthalmologists and ophthalmologists. We were doing a project on amblyopia and strabismus. So you can see here that there are different places of the state of North Carolina. I made this North Carolina map especially for you, Linda, and David Belshas, since those are your home states. So access to healthcare resources is spatially patterned. And then the last thing is that the geographic scale at which you do analysis matters. So that bottom left map gives you a sense of the access to primary care providers that's done at the county level. And you can see here, the darker the color, the lower the access. So you see this huge swath in the Intermountain West where it seems like there's very poor access. And then the map on the right is actually done at the ZICTA level, which is slightly different from zip code, but I won't go into those differences. And you can see a big part of that lack of access to primary care providers is actually because it's public lands out there in the West, and that the pattern of access to care providers is not nearly as good as it seemed when you were operating at the county level. So these four observations drive a lot of our work on how geospatial informatics can shape health outcomes and can shape interventions and responses to health problems that people might be experiencing. So I want to make this point that up is more important than down, and this is very consistent with Bob's talk yesterday. In fact, I told him yesterday that he set me up perfectly. So we are in the habit of downloading a lot of data, getting medical systems to allow us to use their EHR, getting vital records data, all these sorts of things. We're in the habit of doing that. But what we have to take on is the responsibility to upload our results in ways that are accessible and actionable. And I'm going to go through three examples pretty quickly of applying geospatial informatics, and in each of them, I want to talk a little bit about the upload, the up part of this, and the actionability and the accessibility of what we're finding. So the first example is on childhood lead exposure. We've known that lead is a neurotoxicant since 1898. Despite that, we continue to have children in our country who are exposed to lead. We know that there are a series of different risk factors for lead. So for example, this is a map. This is Durham County, North Carolina. I'm on sabbatical at Duke right now. So this is a map of Durham County, North Carolina, mapped at the individual tax parcel level, and it shows you age of housing, where the red parcels are houses that were built prior to 1940. The blue parcels were built between 1941 and 1960, and the buttercream parcels are between 1961 and present. And if you become a geospatial analyst, you will too get up in front of people and use words like buttercream. So this is age of housing. We know that's a risk factor. We also know that household income is a risk factor, that lower income individuals are exposed to more lead. So here's a map taken from the US Census of household median income. Here's a map of assessed tax value. That gives us a sense of how well taken care of the housing might be. And here, the darker the color, the lower the assessed tax value. And especially if you're in the, especially in the South, where there's this mosaic build-out pattern, you'll have these interesting results where you'll have this neighborhood, which has very low assessed tax value, immediately adjacent to a neighborhood that has much higher assessed tax value. The map is much clearer on my laptop. The change in color projection is a little bit different. So this is a map of % African American. For reasons that we don't understand, African American children, even in the same exposure situations, tend to carry more more lead in their blood. So here's a map, again, census data at a different areal scale. And this is whether or not housing is owner or renter occupied. So dark blue being renter occupied, that aqua being owner occupied. And we know that housing tends to be better kept up when it's owner occupied. So we have this information to help us figure out, well, how likely are kids to be exposed to lead? And again, here you see these distinct differences as you move from one neighborhood to another. So then, in order to, so these are all kinds of different risk factors. What we're trying to figure out is how important is one relative to the other. And so what we did is we obtained, over a long-term relationship with the North Carolina Childhood Lead Poisoning Prevention Program, we obtained access to all of the childhood lead poisoning surveillance data. And here, the red asterisk represents blood lead levels that are 15 or above. The current reference level is 5 micrograms per deciliter, although many of us would argue that it should be lower than that. The mustard-colored asterisks are individuals who had blood lead levels between 10 and 15. The dark green are between 6 and 9, and the light green are 5 and below. And these asterisks are actually geolocated on an individual tax parcel. And the map that I'm showing you, just to be clear, these data have been jittered, but because if I showed you the actual location of where these different kids had blood lead levels, that would be a violation of my IRB protocol, right? But when we do the analysis, we do the analysis on the real location of the children. So the idea here is that I have these stacks of data that are, if there's a flat surface, then I have these tax parcels that are drawn on that flat surface, and I have these stacks of data that come out of that flat surface. So there's some data that's available to me from the blood lead screening data. How old is the child? What was their blood lead level? Are they on WIC or Medicaid? And then I have on top of that the tax parcel data, which tells me how old is the house that they were living in, is it owner or renter occupied, what's the assessed tax value, and then on top of that I have some census data, which is at a different areal scale because it's not at the tax parcel level, it's at the block group or the census tract level. So you imagine you have these stacks of data with a fluted top, another stack of data and another fluted top, another stack of data and another fluted top. And so imagine that you're up above all of this and you're looking down and you think, well, that's how I get my answer. It'll be so clear. I'll look down, I'll see all these layers on top of each other and it'll be really clear. And this is what you would get. So hopefully this isn't very clear to you. If it is, we should talk a little bit about counseling. But what you can do is you can take all of those stacks of data, bring them into a statistical program, and parameterize a model around which of these risk factors are more important relative to each other. What's riskier? The fact that is it riskier to live in a house that was built in 1940 but is really well kept up, or to live in a house that was built in 1960 where the paint is peeling? That, trying to weigh those two things is quite difficult. So we brought all these data into a statistical model and parameterized the model, and we get a map that looks like this. And hopefully you can see some spatial patterns in this map. And here, this is what we refer to as one of our 10-10-40-40 maps. The dark blue represents houses that are the top 10% of the riskiest housing in terms of likely exposure to biologically available lead. The dark green is the next 10%. The lighter green is the next 40%. And the buttercream is the next 40% after that. Why is it 10-10-40-40? Because that's what the health department asked us to map. You can, with a few clicks of the button, a few keystrokes, you can change it into whatever display pattern you would like. So what about that whole notion of the upload and making things actionable and accessible? So the up on all of this is that we make the model results freely available, because if you think about it, there's no way for you to know whether a tax parcel is colored dark blue because a child was screened for lead and had a high blood lead level there, or whether that tax parcel is colored dark blue because that tax parcel is a lot like another place where a child was screened for lead and had an elevated blood lead level. So there's no violation of confidentiality for the children or their families. So the health department, we've developed this model for 50 counties in North Carolina and a suite of counties across the United States as well. The health departments use it to drive their blood lead screening programs. They have full access to the model. The housing departments use it to prioritize housing rehabilitation dollars, both applying for those dollars and then deploying those dollars. They can get incorporated into the pediatric electronic health record, so when a physician comes in, they're reminded, boy, we really better make sure that we screen this kid for lead because they're in a high-risk house. We have step-by-step instructions available on the web to construct this model for any location in the United States where the relevant data are available, and we provide consulting for free on if people run into problems. And the results are used by us and by others in their own work. So if you imagine, if you're interested in mixtures work or this full exposome and you don't happen to have information on children's lead exposure, there are these modeled results that you can use and which we will make freely available to you. So this is getting at this point of we need to be in the business of up and not just down. So the second example I'm going to talk about is diabetes in adults. We used data from the Duke Health System where we geocoded about 240,000 patients who visited Duke Medicine and who were in the EHR, who visited Duke Medicine anytime between 2007 and 2011. We used later years to validate. Oh, I should say, we field validated the lead model. We went out and collected environmental samples to make sure that the places where we said there was a lot of lead, there was, and the places where we said there wasn't a lot of lead, there wasn't. So here we used other years from the Duke Medicine database to validate the model. Of these, about 12% of the adult population had a diabetes diagnosis. We also developed a computable phenotype, which we validated with kind of a gold standard chart review on a 10% random sampling. So we have a fair amount of confidence in our computable phenotype. And then we take all this EHR data and we connected it with neighborhood data. So we're very interested in environmental exposures as well as social stressors that affect health outcomes in people. So we connected this EHR data with neighborhood data, and we started running some models. And I know these maps look a lot alike, but I'll tell you a little bit about what the differences are. This model, you got to see some of the really pretty maps before I could, but all your maps are pretty, right? So here, this map right here is if I do a map of the risk of having a severe complication, an amputation, a hospitalization, a diabetes-related hospitalization. Certainly death seems like a pretty severe complication as well. So this is the risk that you're going to have that type of an outcome using only data that's in the EHR. And this is a model that actually uses only the neighborhood risk factors. So one of the things that's interesting to me about this is that you get almost as much explanatory power out of just using the neighborhood risk factors than in comparison to having all of that EHR data available. And then this map right here uses both the patient data and the neighborhood risk factors. And when you do model fit, what you find is that your model fit statistics say that this map is, that this model is the one that provides the best fit, where the EHR data provides key information and the neighborhood information is also very helpful. So just in case you're wondering, my eyeball, so your eyeball doesn't always show you what the patterns are, right? So then it's good to have a full suite of geospatial approaches available to you. So this map right here actually shows you on the difference between this map and this map. So this map shows you where the risk goes up and where the risk goes down, right? So there are all the kinds of really great formal methods for bringing this to bear. So where's the up on all of this? The model results were incorporated into Duke Medicine's electronic health record, and they were used to segment patients. We oftentimes talk about stratifying patients, but it's not so much about stratifying, which seems to apply this sort of monotonically increasing level of risk. People have different types of risk. This person might have more social risk and less medical risk. I might have more medical risk but less social risk. So it segments the population into different interventions that Duke Medicine was delivering. And then the basics of all of this were turned over to the Duke Institute for Health Innovation, and they really went to town with it, and they have taken this algorithm and licensed it to healthcare centers all over the country. So this whole notion of taking the EHR and combining it with neighborhood level data there's an up to it, right? It's getting pushed out to lots of places in ways that are actionable by that physician who wants to know, I've got a patient who is sick now, what can I do for them? So the third example I want to give is not actually, it's not actually linked in the slides that I'm going to show you to health outcomes, but rather it's our latest work and the work I'm just so excited about. I've been frustrated for a long time by the fact that we keep using race as an explanatory variable in all of our models, right? All of us do, right? And I find that very, especially as a person of color, I find that very frustrating, because what am I supposed to say to a community group that I'm working with, like, oh, stop being black, and then your health will be better? That is non-modifiable, right? So we have been working really hard on trying to move the conversation from race as an explanatory variable to the experience of racial minorities in our country as the explanatory variable. So to that end, we developed this measure of racial residential segregation, which is sort of gets at how isolated are particular subpopulations, racial subpopulations. So it measures how likely am I to interact with people of different race groups. And there is no sense in which we believe that if only Hispanics rub shoulders with whites, or if only blacks rub shoulders with whites, that their health would get better, that there would be this weird osmotic transmission of good health. It's more that in these neighborhoods that are isolated with primarily racial minorities, we see a pattern of disinvestment by local governments and by the federal government. So there's this disinvestment. There's a long history of all of this. I recommend highly to you this fantastic book written by Richard Rothstein called The Color of Law, which documents all the policy processes that were put into place that led to the segregated patterns of where people live in our country. It's one of the best books I've read in 10 years. And the other one is you should read Our Kids by Robert Putnam. That's another like blow your mind book. So this is a measure of racial residential isolation, showing this is implemented at the census block group level, and it shows you the kind of yellow pinkish colors, the warmer colors, are where racial isolation is very high. And if you look at the whole map of the United States, you see this very clear pattern in the southeastern United States, which is sometimes, if you look at maps of the stroke belt, they'll look quite similar to this. I'm going to show you some maps a little bit later that zoom in, and you'll see that it's not as if there's no problems in these other parts of the country, but there's this stark spatial pattern in the southeastern United States. We're very interested in educational attainment, and so we decided, well, what if we did an educational attainment residential isolation measure? So this is a measure of if you don't have a college degree, how likely is it that you're going to interact with people who have a college degree? And there are two kind of ways that we're thinking about this. Number one, there's the whole disinvestment argument. And number two is, are there people there who are friends and neighbors and who can help you navigate complex health systems, whether it's the social welfare system or the healthcare system or the educational system, who can help you make the argument. So lots of, we talk about this all the time at the university, right? When kids come to college and they're the first one in their families to come to college, having people they can talk to really explain the details of what's going on, right? So all of you who are at universities, you've been spending time thinking about it. So it's sort of a similar argument here. So this is the pattern of educational attainment, residential isolation, and as you can see, it's on the same scale where the warm colors imply that there's a lot of isolation and the cool colors imply less so, and what you can see is the pattern is completely different for racial isolation versus educational attainment isolation, where here we see in the United States that the educational attainment isolation is predominantly a phenomenon of the rural parts of the country. So we tend to think about education and race being sort of co-varying together all the time, but if I start conceiving this as the experience of individuals in the communities in which they live, we see that it kind of turns that covariance idea on its head. And if I think about, well, how correlated are these things? You don't want to just if you just do like a standard Spearman correlation, it'll come out as being correlated, but it's very important to stop thinking about these aggregate measures, and so we developed a local spatial measure of correlation. I have special thanks to my good friend Alan Galfand who helped us develop this, to see what the correlation is between the educational attainment isolation and the racial isolation. And here's what that correlation looks like, where the hot red colors are highly correlated, and you can see a little bit of blue in here, that's where they're negatively correlated. And the yellow is sort of in between. And once again, you have to think hard about this, because up here in the southeastern United States, they're highly correlated because educational isolation and racial isolation are both high. In Maine, they're highly correlated because educational isolation and racial isolation are both low. Right? So we need to think really carefully about, kind of digging all the way down and going into smaller areas and figuring things out. And this gives you some examples where if I zoom in, instead of using these, whole US maps of these isolation measures, if I zoom in, you'll find that every major metropolitan statistical area exhibits some of this pattern of racial isolation and educational isolation. So the left stack is racial isolation in the, wrong way. I also don't know how to turn on my TV. It's true. I can just feel my daughter laughing at me. I'm used to like pressing the down button on the computer that sits up here. So the left stack is from Kansas, is the metropolitan statistical area from Kansas City. The middle stack is the MSA in the Los Angeles, Long Beach, Anaheim region, and the right stack is the Raleigh-Cary metropolitan statistical area. So you can see, even though those maps of the whole United States made it seem like these areas were just solidly one color or another, when you zoom in, you start to see this. And all of these data, if you're interested in using them in your studies, email me and we will gladly collaborate with you. So this is the place where Bob set me up perfectly. I feel that we spent a lot of time talking about Andy Berwitz's article, The Triple Aim, how are we going to maximize the triple aim, and we were talking constantly about population health. And now we talk all the time about precision medicine. And that is meant to get us to personalized medicine. And I'm on the advisory council for the All of Us program, and I'm really interested in it. But what I love about geospatial informatics is that it allows you to think about personalized medicine at scale to address population health, so you can get to precision community health. To me, the opportunities right now to have a huge impact on how we deliver care, how we prevent disease from occurring, all of those sorts of things, we're at a time of data explosion and idea explosion, and it's a great opportunity, but make sure you weigh in on strengthening transparency to regulatory science so it actually has an impact on the regulatory process. With that, I want to take a moment to thank my research team, the Children's Environmental Health Initiative, as well as the funders of the work that I presented, our data partners, our research participants. Technically, we don't recruit people in, but I think of every single person who's in any of our database as a research participant, and I protect their data as if it were my own. In fact, all of my children are in most of the databases because they were all three of them were born in North Carolina. And I always like to thank our offices of research at Rice, the University of Michigan, and Duke, who've supported us all along. For those of you who've heard me present before, know that I always end with a slide acknowledging my family, because I feel that they make me a better scientist every day. It's really special for me that Marielle, so this one right here, oh, you can't point there. Marielle is here, brought me water. But we have to give a special shout out to this little girl right here, because she has been in bird dog training school. I like to call it Quail University. Come on now. And today she graduates bird dog training school. Yeah. So with that, I'll end and take any questions that you might have.